It will bind lipophilic bases and neutral drugs. To figure out the capacity, you measure their lipids. There's no competition here, so you can't have love triangles. There's no concentration-dependent binding, so that makes it a lot easier. Drugs that are bound to lipoproteins are Probicol, which is an anti-cholesterol drug, cyclosporin, which is a immunosuppressant used in transplant patients, propranolol, which is a beta blocker used for hypertension and lots of other things, digoxin, which is a drug used mostly for atrial fibrillation, but it can be used for other things. This stands for tetracycline, which is an antibiotic, and quinidine, which is an older anti-arrhythmic that you don't use much anymore. All right, so what can alter these binding proteins? So remember, we've dug down. We started at what determines volume of distribution, and we know it's VSS is equal to plasma volume plus tissue volume times fraction unbound in plasma over fraction unbound in tissue. So then we're like, well, what determines fraction unbound in plasma? Well, now we know it's about the capacity and affinity, what binding proteins it's bound to. Are there changes in amounts of the protein, or is there a affinity where two drugs are competing for that binding site? So it's about the capacity and affinity of the drug for that binding site. So what's going to alter the binding proteins? Well, I'm going to just go through these. I don't expect you to memorize them or anything, but I want you to be aware of all these things that can affect our binding proteins. So age, neonates will have less binding to albumin or AAG. The elderly will also have less albumin around, but they have more AAG. This makes sense, right? Because they maybe can't make the albumin, the nutrition's not as good, not quite as healthy, but they might have a lot more problems with inflammation and disease states and using that acute phase reactant, so you'll see increases in the amount of AAG around. Gender. Females have less albumin and less AAG when compared to males. In pregnancy, in the third semester, the mom will have a lot less albumin and AAG when compared with other patients. Smoking will increase AAG. Obesity increases AAG. Nutritional status will alter, right? So I said, nutrition. If you have poor nutrition, you're going to see a decrease in albumin usually. Surgery, you'll see a decrease in albumin and an increase in AAG. Remember, this is acute phase reactant, so times of trouble, surgery. Diurnal variation, there'll be diurnal variations in both AAG and albumin. Renal disease, decreases albumin, increases AAG. Same with liver disease, we'll see decreases in both. This is where we both make liver is where we make both these proteins. An MI, which is an acute myocardial infarction, which I think is now called acute cardiac injury, is an increase in AAG. Any type of cancer or burns is going to be times of trouble, so you're going to have that acute phase reactant released and increases in AAG. In diabetes, you have a decrease in your ability to bind with albumin. Thyroid, specifically hyperthyroidism, you clear these proteins a lot more quickly. Hyperthyroidism is a hypermetabolic state. In cystic fibrosis, you see less albumin. In trauma, of course, you're going to see an increase in AAG. You also see an increase in lipoproteins. I'm not sure why. Crohn's disease, again, increase in AAG. This is an inflammatory response. Again, a time of trouble, so you'll see that increase in AAG. Rheumatoid arthritis, increase in AAG. And obviously, if you have hyperlipoproteinemia, you can see, because of the fact that I think I said we had cyclosporin is a drug that's bound to lipoproteins. So when you have too many lipoproteins around, hyperproteinemia, you're going to have less free drug of the cyclosporin, and we've seen renal transplant rejections because of that hyperlipoproteinemia. So it's really important if you have a patient that's got a transplanted organ and they're on cyclosporin, you got to make sure you follow their lipoproteins very carefully because of the binding. All right, I just went over that. You can also have drug-drug interactions. Those were all disease states, right? Here's drug-drug interactions. So when a drug is displaced, if there's a love triangle and one drug takes the place of the other, it looks like a change in apparent KD, which is that affinity constant. You can have changes in protein binding site, which will also affect that KD, or the affinity constant. If you have increases or decreases in the amount of protein itself, you're going to see an increase or decrease in the capacity, which is the total amount of binding sites available. Whoopsie. Also, here's a list, and again, I don't expect you to memorize these, but it's a partial list. So carbamazepine can be displaced by valproic acid. They're both drugs that are used for anti-seizures, for seizure meds. Diazepam, which is a benzodiazepine that can also be used for seizures and other things, can be displaced by valproic acid as well. Methotrexate, which is used for cancer, it's also used for rheumatoid arthritis, it's used for other chronic inflammatory diseases, can be displaced by salicylic acid and sulfa. This stands for phenytoin or furantoin. Anyway, this is for phenytoin, which is my shorthand for phenytoin, which is a drug used as an anti-seizure drug that also can be displaced by another anti-seizure drug called valproic acid or salicylate. So you see these drugs can all interact, and because they're all fighting for those protein binding sites. This is also interesting. So you can also see displacement of drugs from AAG. So if you are taking a blood sample of a patient that you're going to take to the lab to determine total drug concentration or possibly free drug concentration, you have to be aware of the fact that drugs can be displaced from AAG by plasticizers in the stopper of the tube itself. So you have to make sure that you're careful with what kind of tube you use if you're going to be measuring free drug that's bound to AAG. Also heparin, so many of these tubes have heparin in them so that the blood collected in the tube won't clot. Heparin itself will decrease binding. It can induce the release of lipoprotein lipase and increases free fatty acids, which will displace albumin-bound drugs. I don't think you need to memorize that. Just know don't use a heparin tube if you're trying to determine binding. You also have to be careful that you don't use heat or citrated plasma. That's it. Thanks, guys. Only one more in this volume and protein binding section. Yay!